What we will take you through is essentially a problem-based learning discussion. So let us look at a 55-year-old male with type 2 diabetes mellitus. We initially thought we'll do the pacemakers thing also together. And this was entirely one of our residents, Dr. Dilip. So Dilip's idea was that with their exams looming in front of them to have something with diabetes. I said, like, okay, we'll do it that way. Maybe take in pacemakers, but I think let's see how it goes. We may or we may not have pacemakers in. All right. So what we will try and do is with diabetes, we'll try and figure out what are the diagnostic criteria for diabetes. Then I think a lot of the focus you will realize will be about the preoperative preparation and evaluation of such a patient when he comes in for surgery. We'll talk also about perioperative glycemic control and how you do glucose monitoring. But you will realize that all this ultimately becomes a very small part of the discussion than I think the second part, which is basically evaluation. So, what is diabetes? Well, the term diabetes essentially describes several diseases of abnormal carbohydrate metabolism which are characterized by, and this is a textbook kind of a definition, which is also at the CDC. CDC is right now everybody knows about CDC for the wrong reasons. About characterized by hyperglycemia or and a relative or an absolute impairment of insulin secretion, along with or varying degrees of peripheral resistance to the metabolic effects of insulin. So these are the three things which are essentially part of this disease conundrum. Hyperglycemia, a relative or an absolute impairment of insulin secretion. If you go by this definition, you'll figure out that it is kind of alluding to the types of diabetes that we know of, and also varying degrees of peripheral resistance to the metabolic effects of insulin. Okay. So then if you realize you have this type 1 diabetes, type 2 diabetes, and you can have this entire conundrum. They can be having hyperglycemia, impaired glucose tolerance test, and also they can start off with just a normal glucose regulation. And you also have the other types, and chief among them that we hear about is gestational diabetes. So when do we label someone as having diabetes? Okay, Dilip, since you are the one that, so when do you call? I have given you essentially three columns or possibly even the fourth column. Okay, and there are certain rows. You have a normal person, you have a pre-diabetic, you have a diabetic, and you have somebody with gestation. So, and if you have access to all these reports, when do you say that somebody is normal? At what glycosylated levels? At what fasting sugar levels? And at what oral glucose tolerance test or postprandial, whatever that you think? So when do you call somebody normal?
Diabetic, a normal person. A
Uh,
normal person, when he tests his fasting, it comes down to less than 126, and if it 126 milligram per deciliter,
okay,
and
okay.
uh, if his postprandial comes out to be less than 140 milligram per deciliter, and if his random blood sugar comes out to be less than 200 milligram per deciliter, and if his hemoglobin A1C levels are less than 6.5%.
So this is when you say this person is normal. All right.
Yes, sir.
Remember,
Yes,
we
sir.
have got another row over there, which is a pre-diabetic row.
Yes, sir.
So normal, and this is not something that this grid is not mine. This is directly from the American Diabetic Association. Okay, let me start off this. Okay, normal as per them is when a glycosylated is less than 5.7 with a fasting of less than 100, which is what I think you said, and a oral glucose tolerance test, which is less than 140 milligram per DL, right? Okay, now you can
120,
also,
126, sir. 126.
so this is ADA, this is not me, okay? If your 126 is from what data?
Sir, this 126 is from Harrison. Actually, sir, there is a
So,
very
yeah,
different data which is coming out.
yes, absolutely. You will figure
Because
out that a lot
yes,
of
sir.
thing about diabetes is not absolute. So if you are saying 126 from Harrison, be absolutely sure that you are from Harrison. Okay. So when do you call somebody pre-diabetic?
The pre-diabetic, as per Harrison, what he says is that the oral glucose tolerance test when we do, it should be in between 100 to 126.
Okay. And glycosylated?
But sir, the glycosylated, sir, it should be less than. So for the pre-diabetic, actually, there is no definitive this thing,
Okay.
proper cutoff of hemoglobin A1C. They have just mentioned it that if it is greater than 6.5, then the patient will be termed as diabetic, and if it is not, then it will termed as the normal patient.
Okay. Let's
But
see
for
what ADA
pre-diabetic, there
says.
is no cutoff.
Let's see what ADA says. ADA says that pre-diabetic is between this normal and diabetic, 5.7 to 6.4. And I think this is what I think they have merged it, if I can understand, is this 100 to 125, which I think you were alluding to was 126. So somebody takes something from somewhere, okay? And this is 140 to 190. So essentially, when do you call somebody diabetic, therefore?
Uh, Diabetic, obviously, when the fasting glucose is greater than 126.
Correct.
Yeah, and uh, HbA1c greater than 64,
Okay. And
and
if you are doing just
uh,
a random sugar, which is above 200. So this, by
yes,
the
200.
ADA definition, is what is diabetes. All right. So if you want to label somebody as diabetes, I think that this is now you think that this is kind of getting similar to what even Harrison says, right? Isn't it?
Yes, sir.
A glycosylated above 6.5, a fasting
So the,
sugar which is above 126 milligram per DL, or 7 millimoles per liter, or whatever you want to say, or a oral glucose or tolerance test or a random sugar which is above 200. And when do you call somebody as having
sir,
gestational diabetes?
uh, so gestational diabetes. Uh, Sir, I need to go because I
Okay, okay.
the value.
Acha, ठीक है. So see, as per the ADA, the gestational diabetes is when the fasting sugar is above 126 again. And if again the oral glucose tolerance test is around that 153 to 199. Okay, so I know these are again numbers, and numbers are something which doesn't come naturally to or normally to me, but then you will have to remember this. But at least the red box, I think it is worthwhile to remember a glycosylated above 6.5, a fasting above 126, oral glucose or tolerance test, or a random plasma sugar which is above 200. So I think this is an important slide for
Sir,
exam going students. Yeah.
sorry to interrupt you, sir. Once again, sorry.
Yes.
Sir, in ninth edition Miller, they have stated that the values are completely different, sir. If we even if we are comparing with the ADA, or even if we are comparing with the Harrison, because in the ninth edition Miller, what they have given is that
Mhm.
the fasting sugar level, if they are greater than 110, then he will be labeled as diabetic. And
Uh,
if the
just
as a
yeah, if that's
pre-diabetic
fine.
is,
Yeah, just fine. Just check out. I'm sure Miller would have given reference to what they are quoting from.
yes, sir.
So just figure it out and let
I'll
me
check it.
know. Yeah. Okay. And let us proceed.
Okay,
Okay.
okay.
So let us come back to our patient. Okay, this is this 55-year-old male with type 2 diabetes mellitus who is on oral hypoglycemics and he's on reasonable control. And there was a syncope 5 years back for which a DDD pacemaker was inserted, and he is symptom free from then. There is no history of angina, palpitation, shortness of breath, and the plan is an open inguinal hernia repair. Okay. Okay. Now, this is, I think, something that is a vexing problem. Is it the sugar that causes the problem in a patient with diabetes, or the real problem lies somewhere else? And I think that is essentially the key to evaluation and managing a diabetic patient. And if you realize as you go on, that it is pointless to challenge those numbers, but to identify the real problem which is causing the problem to the person. It's not the numbers, remember, which is causing the problem. So how do you identify the problem? So the problems that are is again with either what the disease is doing to the various organs, or the association of the disease with certain other metabolic problems. So the comorbidities which complicate perioperative care are the cardiovascular disease, the association strongly with obesity, and again things like hypertension, neuropathy, nephropathy, and these leads to the complications, and this is something that you need to work on. Okay, so this is I think what I think everybody knows. So when you're looking at preoperative preparation, and then you're looking obviously at evaluation, so what are you trying to evaluate? You figure out you are trying to evaluate two things: the story of the diabetes and the organs that are affected. Now, what are you trying to figure out from this diabetic story? What kind of diabetes it is? And I think this is the easiest to figure out. Then, yes, you want to figure out how good or bad the level of blood glucose control it has been, what kind of medication regime this person has, and does the person have something which people have started recognizing a lot these days is hyperglycemia per se without a diagnosis of diabetes. And why it is important to realize that, you'll soon realize, because this group of patients can be extremely troublesome. Okay, and the organs affected, I find it easier to just remember and classify it this way: as the macrovascular disease problems like the coronary artery disease, the cerebrovascular disease, the peripheral vascular disease, all kind of related to atherosclerosis, and the microvascular disease or the small vessels, which is causing the retinopathy, nephropathy, neuropathy. And if you realize that there are certain things which becomes which are more important than the others, and you'll be really bothered about things like a coronary artery disease, you should be bothered a little bit about cerebrovascular disease when it is apparent, and definitely nephropathy. But when you realize that neuropathy, which takes up the bulk and also has got to do as to how you tweak your anesthetic technique as well, or how you manage the anesthetic bit of it. Okay, level of blood glucose control, how do you evaluate? You obviously try and find out, if you know the history and record, what has been the range of blood glucose level that this person has been sailing through, what has been the average over the last 3 months, 6 months. Knowing the glycosylated hemoglobin levels definitely help. And but I think it is here that you possibly can spend a little bit of time with the person, as to have they experienced something like an hypoglycemia, are they aware of something like that, it has ever happened to them, how often has it happened, at what glucose levels, if they have been checked, that's that happened, and what has been the severity of symptoms. Now, why are we trying to find this out? The reason we are trying to find this out is obviously that it can be helpful in reducing or deducing how much of the insulin dose that we need to tweak in the preoperative period. And maybe we just don't stick to whatever all textbooks tell you, but individualize for this patient that this is possibly a good perioperative blood glucose target for this particular person. So, this is why you need to evaluate the level of the blood glucose. Now, why do you want to know the blood glucose levels? Except to figure out that, well, this person is good control, not good control. You see, there is something with the blood glucose level, the something with the blood glucose control, which can influence outcomes. And there has been enough studies which have found a direct correlation between elevated glycosylated levels and adverse events like infections in the perioperative period, and worse cardiovascular outcomes after cardiac and non-cardiac surgery. Okay.